A 65-year-old man is hospitalized with acute dyspnea, dry cough, fevers, and confusion. His vital signs show a low-grade fever at 38 degrees Celsius, heart rate is elevated at 102, blood pressure is normal, respiratory rate is 25, oxygen saturation is 81% on room air. On exam, he has scattered crackles, splenomegaly, and pylore. His labs show white blood cell count of 321,000 with 95% myeloblasts. Hemoglobin is 8.1. Chest x-ray shows bilateral pulmonary infiltrates, and broad-spectrum antibiotics are started. The question is, which of the following is the most appropriate next step in management? Let's go through the options one by one. Option A is TPA. This is a thrombolytic, can be used in acute PE or stroke. In this patient, a PE is unlikely, so TPA is not going to be indicated. Option B is IV furosemide. So diuretics are typically used for fluid overload, like in heart failure. But here, giving a diuretic could actually increase blood viscosity, which can potentially worsen the vessel occlusion in the lungs. So this is not the right choice. Option C, cytarabine and daunorubicin. This is the standard induction chemotherapy for AML, acute myeloid leukemia. This is actually the correct answer. Why? Because patients with extremely high blast counts, like our patient with over 300,000 white blood cells, they can develop leukostasis. Leukostasis is when pulmonary or CNS blood vessels get clogged with blasts. Remember that blasts are going to be a lot bigger than your regular WBC. And so because they're big, they can easily get clogged when they accumulate within the vessels. And this can cause shortness of breath and hypoxemia, like we see in our patient. It can also cause low-grade fevers. And the central nervous system may also be affected when the CNS vessels get clogged, and that can result in neurologic symptoms such as confusion. A chest x-ray will often be clear in leukostasis as the abnormality is in the vessels. Now, when it comes to the treatment, induction chemotherapy to rapidly reduce blast counts is going to be our first option. In some cases, leukapheresis is also used if chemotherapy is delayed. And so remember that leukapheresis is the process in which we separate WBCs from rest of blood to reduce their count. Now, regards to the question, a couple of tips on why this is AML and not ALL, which is the other type of acute leukemia. We can determine that we're dealing with AML in this scenario by looking at the blast type. Labs show in our patient 95% myeloblasts. Myeloblasts are characteristic of AML. ALL, on the other hand, would show lymphoblasts, which have a different morphology. They're often smaller and they have a condensed chromatin. Extreme hyperleukocytosis, which is usually considered a WBC above 100K, is going to be more typical in AML, especially the M4 and 5 subtypes, which are the monocytic variants. Let's move on to option D. Heparin, again, this is used for thromboembolic events. Since PE is not the cause, anticoagulation is not indicated. Option E is methylprednisolone, a glucocorticoid. While steroids are useful in some leukemias, they don't treat leukostasis, so this is not the right choice either. So the key learning point is that in patients with AML and extremely high WBC counts, watch out for leukostasis. The most appropriate treatment is going to be induction chemotherapy, and in urgent cases, leukapheresis can be used to temporarily reduce the WBCs.